Hi, my name is Ariana Vera. I am going to talk about preterm ovarian hyperstimulation. Definitions is a rare condition found in preterm female infants born between 24th 31 gestation with, characterized by vulvar, hypogastric and hypolexilin, elevated serum, estradiol and gonadotropin levels, and ovarian follicle cysts. The main etiology is the immaturity of the gonadal axis and the lack of negative feedback of the placental steroid.
Ovarian hyperstimulation is a condition that occurs when the ovary is stimulated, usually by injectable follicle stimulating hormone. It happens most commonly in young women with a very large egg reserve. And they typically with IVF will get 20 or maybe 30 eggs retrieved. After the retrieval, those follicles reactivate, continue to make estrogen. And when those follicles refill with fluid, that fluid begins to leak over the surface. And it's mediated by a protein that we know about. And again, the women who get this syndrome are genetically predisposed. Unfortunately, we don't know how to identify those women specifically, other than those women that have a lot of egg reserve. And classically, it's a polycystic ovarian disease woman that has 30 resting follicles that is much more likely to have this condition.
Applications in medicine. Phytomonicin of bush is sealing which develop around 37 plus slash dash 3 WPC8, and the syndrome is only frequently diagnosed when the ceiling is profound. The direct etiology factor here is not E. Push does not require therapy as long as there is no danger of seed torsion.
Women who use fertility medications, particularly those drugs that stimulate multiple follicles to develop, are at risk of a disorder called ovarian hyperstimulation syndrome, also known as OHSS. OHSS is the result of stimulation of the ovaries with medications. It doesn't happen in very many people, but it can occur in up to 5% of women to a significant degree. In a small portion of those women, hospitalization is required. The medications used for ovarian hyperstimulation cause the ovaries to become leaky. Sometimes fluid will exude from the ovarian tissue into the pelvic cavity, causing women to fill up with fluid in their abdomen. Sometimes that fluid can actually travel up to the spaces outside the lungs and cause difficulty with breathing. These are only, however, in the most severe cases. Ovarian hyperstimulation syndrome is often preventable. If a reproductive endocrinologist is monitoring the cycle very carefully, looking at blood estrogen levels and ultrasound examinations during the stimulation cycle, that doctor can often prevent OHSS from occurring. Some women are much more prone to OHSS than others. For example, young women, women with lots of follicles, for example, women with polycystic ovary syndrome, are the ones who are most susceptible to OHSS. Should OHSS occur, the treatment is usually just supportive care. In other words, the disorder always goes away by itself. However, the symptoms can be very difficult, and in most severe cases, it can be life-threatening. In severe cases, women might have to be hospitalized and receive intravenous fluids. In some cases, a needle is placed into the abdominal cavity and liters of fluid extracted. This can help the patient feel like she can breathe more easily and urinate more easily. Ovarian hyperstimulation syndrome occurs in many women. However, it is only severe in a small minority. A good reproductive endocrinologist who is board certified and trained in the management of fertility patients and ovarian hyperstimulation syndrome is required to avoid the complications of this disorder.
Pros and cons. Pros. Easy diagnosis. Generally resolved on its own within a week or two. Somewhat longer is the pregnancy. Cons. Severe symptoms are shortness of breath, pleural effusions, urination significantly darker, marked abdominal bloating or distensions, and lower abdominal pains. Use applied in Ecuador. For ovarian hyperstimulation syndrome, your doctor may make a diagnostic based on a physical exam to check the weight gain increased in your right side and abdominal pain, and ultrasound to show that the ovaries are bigger than normal, with large fluid filled sites where follicles develop.
Hi, this is Brooke, and today I'm going to talk about a case of ovarian hyperstimulation syndrome. And this case involves a 39-year-old woman, G2P1, who is 7 days status post an IVF embryo transfer. Her chief complaint was severe shortness of breath, where she could not take any more than 2 or 3 steps without being unable to breathe. She had abdominal distension and nausea without vomiting. Otherwise, her review of systems was largely negative. She did not have any vaginal bleeding, chest pain, leg swelling, cough, or any other GI complaints. On her exam, her vital signs were as follows. She was a little tachycardic, maybe a little tachypnic at times, breathing at 97% on room air. Her abdominal exam was mildly distended with moderate diffuse tenderness to palpation without rebound or guarding. Her lung exam had markedly decreased breath sounds on the right and also diminished at the left base. Her extremity exam was unremarkable. Her lab work was only remarkable for a leukocytosis of 21, a slight elevation in her HCG of 83, and otherwise her lab work was unremarkable. We performed a bedside ultrasound, and this is her right chest, where here, this is the liver, this is the spine, and an enormous right-sided pleural effusion. You can even see it swirling here. And this is a good example of the spine sign, where normally past the diaphragm you would not be able to see the spine, but here you can see it very well. On the left side, you can see a smaller pleural effusion here. And further interrogating the right upper quadrant, here's the kidney, the liver is here, and the Morrison's pouch does not seem to be very convincing of free fluid, but this is a perfect example of why it's so important to look at the inferior pole of the right kidney, because she has significant fluid here and it's only seen at the inferior pole. This is further interrogating the left upper quadrant, and here again you can see the left-sided pleural effusion, but you also see a lot of free fluid underneath the diaphragm, between the diaphragm and the spleen. Again, this is a great example where the splenorenal space looks pretty clear, but you can miss a significant amount of free fluid if you don't interrogate the space between the spleen and the diaphragm. This is her pelvis, and the clip above focusing a little bit more on her right adnexa, where you see large ovary and multiple cystic structures. And here at the bottom on the left, you can see her left adnexa is the same. So on both sides, she has these huge ovaries with multiple cystic structures. So this woman met the criteria for ovarian hyperstimulation syndrome. And it's not something we see very often in the emergency department, but it's an iatrogenic complication that's seen in 3 to 6% of women undergoing assisted reproduction. And the symptoms and the manifestations are due to increased vascular permeability that leads to third spacing of fluid. And it's a large spectrum of disease where it can just be enlarged ovaries and mild abdominal pain, all the way to pleural effusions, pericardial effusions, thromboembolic events, ARDS, and death.
And conclusion. Preterm ovarian hyperstimulation syndrome shall be considered as part of the differential diagnosis of ambiguous appearing genitally, as it is a self-limit syndrome that does not require treatment. Houseless, you are at risk for torsion, bleeding, or rupture. Elevate estradiol levels and ovarian sites can confirm the diagnosis. Babies with PUSH shall be followed closely during infancy, monitoring for cyst regressions, and again that puberty for polycystic ovary syndrome, metabolic syndrome, and reproductive dysfunctions. Thank you.